Good evening, everyone, and welcome to today's webinar on what's new in flu, current challenges, and management option. For this webinar, today we have with us a guest speaker, and I would like to take a moment to introduce them. Today we have with us Dr. Pramod Jog. Dr. Pramod Jog is a pediatrician and neonatologist from Pune and has an experience of 38 years in this field. Dr. Pramod Jog is a professor of pediatrics at Dr. D.Y. Patil Medical College, Pune, and also he was an ex-president of Indian Academy of Pediatrics in 2016, ex-standing committee member of International Pediatric Association, and ex-steering committee member of Gavi, CSO, SC. Dr. Pramod Jog practices at Jog Children's Clinic in Pune and Aditya Birla Medical Hospital in Pimpri Chinchwad, Pune. He completed his MD Pediatrics from BJ Medical College in Pune in 1985 and MBBS from BJ Medical College in 1981. So with this introduction, I'll request Dr. Pramod Jog to start our webinar.
Thank you, Manor. I am sure you are able to hear me. Yeah.
Yes, sir.
Thank you. And we will start it. I will just start sharing my screen and just give me a moment.
Yeah.
I hope the screen is visible. I will make it full screen. Okay. Right. Now it's seen, I suppose. Okay. Very good. I'm sure now the screen is seen. And am I also audible also? Thank you.
Right, sir. You're audible.
Thank you. Yeah. Thank you very much. Okay. So without wasting much time, now we will discuss the topic on what is new in flu. Okay. Flu is not new, but there are many things which have happened in the field of influenza. Okay. And there are quite a few challenges in dealing with influenza. And I'm going to, take you through what has happened over last few months. And all of you know that, we were all in the era of COVID during 2020, 2021, 2022. And then in 2022, somewhere in the months of July and August, slowly and gradually, we started thinking that now COVID has gone and let us enjoy life and let us have disease-free moments. So slowly and gradually, we were about to relax mentally. But then if you observe one by one, there were surges of certain epidemics. I remember in the months of June, July, and August, there was an epidemic, at least in my place, that is in Pune, of hand-foot-mouth disease. Okay. After that came that respiratory syncytial virus. Then came H1N1. And then came adenovirus. And then came H3N2. So likewise, so many viruses started making their appearance. Now, I was wondering as to why is this happening? And to the best of my clinical judgment and experience, what happened was during 2020 and 2021 and 22, all of us were inside the houses, majority of us. Children were not going to the school. And these viruses, as if were waiting to attack children and to some extent the adults also. So when children did not have any immunity against influenza or maybe adenovirus or RSV, then these viruses, they started attacking children. And as schooling had started, all these viruses, whenever children started going to the school, started attacking one by one. And as you know, influenza has a high transmissibility. Okay. So from one child, the virus immediately spreads and the incubation period is so short. Within 2 to 3 days, the other child also starts showing symptoms. And this is probably the background of what has happened over last few months. And recently I had a small little girl who came to my clinic with a small little doll in the hand. And while I was examining this cute girl of about 5 or 6 years, this particular girl was speaking to the doll and telling her, don't worry, it's viral. Okay, so even small little children these days, they know that there is something like viral fever, and this is self-limiting. And many of the parents, they know that there is no need of any antibiotics for all these viral illnesses. But my dear friends, the situation is not so simple. And many of us have become really, really scary of the viral infection. So the moment somebody says it is viral, many times I myself get scared. Okay. And then after this post-COVID period, what we have seen is, in addition to the waves of different viruses, even the older children are getting affected to some extent. And in the OPD, you can see that children are coming with recurrent respiratory tract infections. One of my, receptionist's, son, he just came in the month of January. And the receptionist said, sir, that my son is unwell. I gave him some symptomatic treatment like paracetamol and some antihistaminic. The child improved, went to the school. Again, after a fortnight, this chap came back. Again, after a fortnight, this chap came back, to the extent that the receptionist said, sir, you have been treating so many children for so many years, and I have now started losing confidence in your treatment. And I was really, really scared. And my dear friends, remember, particularly if a child is brought to your clinic with repeated history of these respiratory infections, never ever forget to examine this ear, nose, and throat, because quite a few children, they start developing sinusitis with these recurrent respiratory infections. Of course, back-to-back viral infections are not uncommon in our day-to-day practice, and that's what we survive on. But then doesn't matter. Remember that this has been very, very common, and I'm sure our colleagues are aware that this particular problem, really, really there is no answer, really no answer. And we have witnessed a rise in the number of cases of otitis media. You know that the sinuses and the middle cavity, they're all connected, and they're all the part of the upper respiratory tract. And the same viruses which produce rhinitis and the same ones which produce pharyngitis, they are the ones which will create problems in the sinuses and in the middle ear. And that is why we have seen children with adenoidal hypertrophy to a greater extent. And as I was talking to you, unseasonal surge in influenza. You know that most of us have influenza, which attacks particularly in the periods of April, May, and June. However, this time we had the unseasonal surge in influenza in the months of this January, February, March. And the adenovirus, which came again in that particular period, had so many different manifestations. We all know that adenovirus usually comes with, cough and cold, pharyngitis, but there is a follicular tonsillitis. There is discharge from the eye, and that is one characteristic feature of adenovirus. It also comes with mesenteric lymphadenitis. It also comes with hemorrhagic cystitis, and so on and so forth. So what you should be aware that these viruses have started behaving differently. And some of my friends ask me whether it is related to the COVID and whether COVID has changed the behavior of these viruses. No one really knows the answers, but one should be aware that these things are happening. And the prolonged illness of adenovirus is also something being witnessed. Usually we used to say that viral illnesses, they disappear within 3 days, at the most 5 days. But then this adenovirus typically is taking about 7-8 days, to settle. The fever doesn't settle fast. Okay. And when we examined these children, we had, high CRP. And when we came across the literature about influenza and adenovirus, we came to know that these are the two viruses which are notorious to have the CRP on the higher side. And during COVID also, we have witnessed high CRP. The nasopharyngeal swab, many times we used to get different viruses, particularly the innocent bystanders like rhinoviruses, along with influenza, along with adenovirus. And we also need to know as to which are the nasopharyngeal organisms which need to be considered seriously. And then we had a therapeutic dilemma about use of antibiotics, because when the fever doesn't go down in 3 to 4 days, or maybe at the most 5 days, then the pediatrician also starts becoming jittery, and the pediatrician is tempted to prescribe antibiotics. The pediatrician also tempted to start the anti-flu medication, Many times children, they required metered dose inhalers, and some of them who used to come with recurrent respiratory infections and runny nose and nasal blockage, they were put on nasal steroids, the intranasal steroids. So the picture of these viral illnesses and the spectrum of viral illnesses has posed quite a few challenges over the last few months. And we are now facing a small little child, his Viru because he has a viral infection, and he has fever for 3 days with cold and cough, and he is on metered dose inhalers since 4 months. And he was actually well controlled with symptomatic treatment, and he has come back after 3 days. As I told you, the story of my receptionist, this child is afebrile for a day and again gets fever. He has been active in between, and viral illnesses are known to have a normal interfebrile period. You give paracetamol, the child improves, and during that particular afebrile period, he is quite playful. Recurrent viral infections have really become more frequent, and these infections are occurring at a shorter interval, and it's always a big challenge whether we put these children on antibiotics. However, one has to remember the differences between a viral and a bacterial infection. So when parents come across in front of us, what I tell them is that, see, I already told you the story of how COVID has probably altered the behavior of viruses. One should also be aware and tell the parents that, for example, the adenovirus, as I told you, the course has become prolonged. And many times I have seen this adenovirus creating problem and a fever up to 3 weeks. Okay. So I tell them that, don't worry. This particular fever is because of this adenovirus, and it will take about 3 weeks to settle. And if the child settles in 2 weeks, well, Dr. Jog has given a correct advice. And that's why I remember that the parents must be told that these are viral infections. And what are the features of viral infection? Remember, there is multi-system involvement. So the same virus will produce runny nose, the same virus will produce cough, the same virus will produce discharge from the eye, the same virus will produce a bit of rash on the skin and upset in the tummy and vomiting and loose motions. So more than one system is involved in this particular condition, while bacterial infections are localized. When you get a child with tonsillopharyngitis, which is bacterial because of group A beta hemolytic streptococcus, then there are follicles on the tonsil with a tender cervical node. But in this particular child, there won't be pneumonia. This child will not have rash. This child may not have loose motions and vomiting. So it's an involvement which involves only one particular organ. And that's why you should know that viral and the bacterial infections are different. The interfebrile period in a viral child, the child is absolutely normal. The mother will say, sir, when the fever comes down, the child starts literally playing around and starts hitting his elder sib, and then he's back to his usual self. But whenever there is a child with bacterial infection, fever goes down. But the mother says, sir, he is not the usual self. He is a bit different. He is sleeping. He is not eating well. He is not smiling. Then you should think of a bacterial infection. Okay. And it is very important to know as to who loves whom, meaning thereby, which are the organisms which attack a particular part of the respiratory system. For example, if you want to identify the enemies, remember that if the onset of the illness is with cold and sneezing, then it's a rhinovirus. Okay, the onset is with cold and sneezing. It's common cold. The upper airway is involved. There is either mild fever or no fever. There is no exhaustion. The child is hale and hearty and quite playful. These are influenza and parainfluenza and respiratory syncytial viruses. Okay. If it's along with high fever, with prominent headache, myalgia, and extreme exhaustion, remember it is flu. So today, on day one, whenever a child comes with high fever, but with headache, muscle pain, and extreme weakness, then you are fully justified in starting oseltamivir for these children, because epidemiologically, this particular virus is there in the atmosphere. And we know that earlier A few months back, it was H1N1, but now it has been H3N2. Both are from influenza A group only. However, the H3N2 virus is predominant in the society, in the atmosphere. And then if it's adenovirus, as I told you, it's pharyngoconjunctival fever. And the child will have discharge from the eye along with fever, along with pharyngitis. There would be exudative tonsillitis, and there would be diarrhea, and there could be mesenteric lymphadenitis and hemorrhagic cystitis. We have seen children with adenovirus, as I told you, producing fever for a little prolonged time. Okay. And also remember that this virus persists in the respiratory system for quite some time. And I have friends who tell me that it persists for even for a year or so. So you have to be really aware. And remember that all these viruses these days can be detected from the nasopharyngeal swab. Okay. So in case if you get adenovirus, if you get influenza or parainfluenza, or the respiratory syncytial virus, or there is another one called human metapneumovirus, and if the child is worsening, then you can very well take these viruses as the reliable indicators of that lower respiratory infection which the child has. But rhinovirus, usually, as I told you, just is an innocent bystander. Just as you know, sometimes the husband and the wife are fighting and the neighbors are looking to their fight. So the neighbors are innocent bystanders like rhinovirus. They won't create any problem. They will only observe. Okay. Similarly, you get a sample of the nasopharyngeal swab wherein you get adenovirus plus rhinovirus. Don't worry, mainly it's adenovirus because rhinovirus, always is present in the nasopharyngeal flora. Okay. And then, as I told you, under the age of 1 year, bronchiolitis is most commonly because of the respiratory syncytial virus. And if there is fever with lower respiratory involvement, dry cough, breathlessness, then always suspect COVID-19. And in an older child, you may get loss of the sense of the taste and the smell. And if they are the bacteria, like the streptococcus, then you would have fever with follicular tonsillitis, a tender cervical node on one or two sides. And if the child has fever and grunting and tachypnea, then you think of pneumococcus. Okay. The mother will say that, sir, during the night time, the child grunts like, so that is grunting. जिसे हिंदी में आप कराहना बोलते हैं. So that is, something which, you should be aware of. And the respiratory rate obviously will be high. You know that there are cutoffs given by WHO up to the age of 2 months. If the respiratory rate is above 60, within 2 months and 1 year, if the respiratory rate is above 50, and beyond 1 year, if the respiratory rate is above 40, then usually it's taken as an indicator of pneumonia. And then you are fully justified in treating this child as per the guidelines. Okay. And an infant or a child who is under the age of 2 years, if shows rapid progression and toxicity and rapid worsening, it usually indicates staphylococcus. And beyond the age of 5 years, if there is predominant cough, then we should suspect mycoplasma. Now, recently I had this particular child who was a 4-year-old child with cough and fever of high grade for the last 5 days. And you can understand that if the child continues to have fever for 5 days, parents would be restless and even the pediatricians would be restless. Okay. And when he was brought to me, he had this particular X-ray picture, and you can obviously see that on the right side, we can have the involvement of the parenchyma. This chap was not settling with oral medicines, and on admission, he was tachypnic and he needed oxygen support. His hemoglobin was 11.6. The total count was 1620. See the leukopenia, and the platelet count was also on the lower side, and that was 132,000. SGPT and SGOT were deranged to some extent, and nasopharyngeal aspirate came positive for H3N2. And this was a child who had influenza with low WBC count and low platelets. The point that I want to tell you is that these days, if a child comes to you directly on day 1 with high fever, maybe with chills, along with headache, along with myalgia and weakness, please take it to be influenza, because epidemiologically there is influenza around and you are justified in giving oseltamivir. If he doesn't have these symptoms, but only has fever, wait for 3 days, don't give antibiotics. give paracetamol, give antihistaminics, okay, give him plenty of fluids, wait for 3 days. Fever doesn't go down, then you are going to have the complete blood count, urine routine, and an X-ray chest. If the blood count shows lymphocytosis, or if the child doesn't have high CRP, again indicative of viral, then you can very well wait. But if you find that the CRP is high, then it could be even adenovirus, or it could be a bacterial infection. So on day 3, you have some indicators to indicate whether it is viral or bacterial, and then you can put him on amoxicillin. Okay, you know that amoxicillin plain, not amoxiclav, is the drug of choice for respiratory infections at the end of day 3, provided you are thinking on those lines. By the end of day 5, if he still doesn't respond, then you are fully justified in sending the nasopharyngeal swab, provided this particular child is worsening, the oxygen requirements are increasing, the respiratory rate is increasing, the child is becoming breathless, the child probably needs hospital admission. Okay, so these are the children wherein you can always send a nasopharyngeal swab. If it shows influenza, then obviously you are going to put this child on oseltamivir. If there are no indicators of influenza, but there is an adenovirus in the swab, then you are not going to do anything, just wait and watch. However, there will be pediatricians and they will be fully justified in putting this particular child on IV medication like ceftriaxone, because it is not that adenovirus will not have in association a pneumococcus. Okay, it's quite possible that both these infections persist together. The child is highly toxic. We have been waiting for the last 5 days, 6 days for the fever to go down. It has not yet gone down. So it's individual choice whether to continue only with antipyretics, antihistaminics, or whether to put him on injection ceftriaxone. One won't say anything, in case if one starts with injection ceftriaxone with IV fluids and gets this child admitted in a hospital. But remember, whatever is the organism, this tachypnea, the need for oxygen support is something which you must always keep at the back of mind. And then another child of H3N2 who was 3-year-old with cough, fever for 5 days, the fever was not settling again, the counts were normal, and the nasopharyngeal swab showed H3N2. Again, this particular child with cough, cold, fever, I tell you, CRP here was 38, wherein the nasopharyngeal aspirate showed H3N2, and you can see involvement of the right side of the lungs. Okay, these are all the cases which I just saw in the last 2 months. And another child, 1-year-old with fever, cough, cold, and status epilepticus. He came convulsing. Nasopharyngeal aspirate showed H3N2. The counts were normal. The MRI showed non-specific changes of encephalitis. The CSF was normal. And we labeled him as a case of influenza encephalitis because the nasopharyngeal aspirate clearly showed H3N2. And another girl, Flora, 7-year-old, a daughter of IT sector parents. Remember, IT sector parents, I am always very careful, because IT doesn't mean only information technology, but it means inquisitive and troublesome. And these parents, of course, under tension, anybody would behave in a different manner. I am, quite convinced about it. But then this daughter of these IT sector parents had high fever for 3 days with throat irritation. And they had an exam 2 days later, and the throat was mildly congested. And I just gave paracetamol, and then flu and adenovirus being around, they were always after me as to, ask me as to what do we do and how to manage. So I did the CBC and CRP and sent a throat swab. Though I did not have, the proof for the influenza, in view of the symptoms related to this particular scenario, these parents were about to, rather tell me to do something or the other. Now, the question is whether we put this particular child on oseltamivir. Remember, my dear friends, in case if a child has headache, if he has high fever with chills, if he has pain in the muscles and weakness, then you are justified in putting this child on oseltamivir. Okay. But if a child has mild fever, if a child has only throat irritation, the congestion is very mild, then you can always hold on. But you have to tell the parents. Okay. Now, why one thinks of oseltamivir is because these children who have influenza, in case if you give acyltamivir in the first 48 hours, then the response is better. But most of us who have seen this 2009 pandemic of H1N1, they know that with oseltamivir, fever of H1N1, even H3N2, just melts like anything within 24 hours. Okay. And the child is improved. The child is better. And this is because the antiviral has been given to a child who has definite diagnosis of influenza. Okay. So remember that response to therapy is quite dramatic and child symptomatically improves. And another child, just for your information, he was a 3-year-old boy with cough for a week and high fever for 3 days with crepitations. And he was put on co-amoxiclav because this child had high fever and respiratory involvement. And he was admitted for persistent fever. That's fine because the child was not improving and he has respiratory signs. Okay. He was put on intravenous amoxiclav and the counts were normal. The CRP was normal. However, the throat swab was sent because this child was hospitalized and that showed influenza A and oseltamivir was added. Now, you will ask me, sir, it's okay. There was influenza. You started oseltamivir, but do we stop the antibiotic once we get a throat swab showing, influenza? Again, I tell you, if the child is unwell, if the child is sick, okay, it is individual decision. This is because influenza also, just as I told you about adenovirus, many times if you have both these organisms like one bacterium and one virus together, then you are justified in continuing the antibiotic. Though ideally one would say, no, sir, we will continue only oseltamivir, fine. But it all depends on the child. Why I'm trying to tell you, because 25% children with flu have associated bacterial pneumonias, 1/4. Okay. And that's why you should know this particular fact. And now this particular child, today morning, the younger sib who is 8 months old comes to me with high fever since yesterday. Now, what will you do? Now, my dear friends, here you have swab which is showing positivity for influenza A. And here there is no doubt that you will give oseltamivir to the younger sib who has come with high fever since yesterday, because I told you in the beginning that the transmissibility of influenza is very high. And whenever a sibling comes, where there is definite positive swab in the other sib, you are justified in starting oseltamivir. So if you want to know your customer, that is KYC that we give to the banks, KYC of influenza. So we will have to find out now what has happened to this influenza, what are the complications, and then what are the evidences for the use of oseltamivir and general guidelines in the use of influenza. Now we have seen over last few months that this H3N2 virus has been linked to these cases of high fever and cough, and the cold wave and the fog and the rising pollution, they have triggered the surge in the seasonal influenza cases. And the private hospitals, they have seen flooding of cases all across the country. Okay. So we know that flu is seasonal, but now it has not remained seasonal, but it has become now a perennial condition. Okay. And the viral infections have been in full swing. H3N2 very much is in the air, and the infection in the pediatric patients, it has been now dragged for a longer time. Okay. And as I told you, the rising pollution and the temperature fluctuations have led to significant rise in the flu-like symptoms. And remember this huge surge of flu cases. Remember runny nose, fever with cough, sore throat, body ache, and in children, many times what we have is vomiting and diarrhea with muscle pain and weakness. You can always rest assured that this is influenza. You'll find that parents will just lift the child and bring an older child also. And these are the children who have influenza. Okay. And if we look at the ICMR network of laboratories, in the initial 9 to 10 weeks of this particular year, we have found that in individual weeks, if you see influenza H3N2 has been always on the higher side. And we also have had cases of severe acute respiratory infections, SARI and ILI, that is influenza-like illness cases. Okay. And the healthcare related challenges have also been there because it's a diagnostic dilemma. We always used to think that it is likely to be only H1N1, but no, it's also H3N2. And then we have severe acute respiratory infections, and there is always a confusion whether it's COVID-19 or whether it is a twin-demic of influenza with COVID. Okay, and that's why COVID being always at the back of mind for all those 2-3 years now, we have to always think on those lines. And the dynamics of the occurrence of influenza in relation to seasonal variations was studied in Chennai. And this study was done in the Department of Virology 2-3 years back. And remember that about 36,000 specimens were subjected to influenza studies, and the duration of the study was 7 years. And the influenza positivity started with the onset of monsoon and peaked during the post-monsoon months. This was the dynamics of occurrence of influenza. However, if you see the incidence of influenza and the related deaths, they have been increasing alarmingly in India. You can see that in this particular slide. These are the deaths due to influenza infection. And in the year 2019, there have been almost 28,000 and odd cases of influenza infection and almost 1,200 and odd deaths due to influenza infection. And you all, as learned pediatricians, know that influenza virus is one of the most common infectious disease, highly contagious airborne disease, comes in seasons and manifests as acute febrile illness, and serious outcomes are known which result in hospitalization or even deaths. And you know that there are different types like influenza A, which is known to be associated with epidemics due to the antigenic variations every year, and periodically there are pandemics due to major antigenic variation, like these are called as the shifts and the drift. Okay, and influenza B viruses, they affect the human beings and they produce local epidemics, not the pandemics. Okay, and influenza C, it infects the humans and the swine, and the type C infection generally causes a mild respiratory illness and doesn't produce epidemics. But the current circulating subtypes are H1N1 and H3N2. Okay, and you all know that people with flu, they spread it to others who are in about 6 feet distance, and they are mainly transmitted by droplets. And all those precautions that we have been taking for COVID, they hold true for influenza. Okay, and people should stay away from the affected person and stay home if they are sick. And we all know we have to wash the hands with soap and water frequently. And most of the healthy adults may be able to infect other people beginning 1 day before the symptoms develop and up to 5 to 7 days after becoming sick. And I appeal all our pediatricians to keep wearing masks, okay, during this particular period, which is a very critical period. And some parts of our country are showing rise in the cases of COVID also. And that's why we have to be very careful, because as healthcare professionals, we have to take care of our own selves. Quite a few of us are hypertensives and diabetics and high risk obese individuals, and we should not get infected for no reason. Okay, and remember, children may pass the viruses for longer than 7 days. And if you see the symptomatic differentiation of influenza-like illness and H3N2 and the severe acute respiratory infection and COVID-19, you will find that fever, myalgia, cough, and lack of energy, that is weakness, and sore throat, they are all common. Breathlessness in influenza-like illness may or may not be there, but loss of sense of smell and loss of sense of taste, which are very particular for COVID-19. Diarrhea is also particularly for COVID-19, and headache, as I told you, yes, in H3N2, it is known, and one has to be aware of this. Why I'm trying to show you all these important clinical features is because even Rajinikanth, the superstar of South, cannot differentiate as to what is this virus. Okay, and that's why you have to be very careful in the beginning of this particular illness. I told you it's very difficult to differentiate these viruses, but in case if a child has some important symptoms, which I told you, high fever with pain in the muscles, with weakness and headache, please remember it could be H3N2 and you are justified in starting oseltamivir. And I told you that in children there are some warning signs like fast breathing, which all indicates that respiratory involvement is there with cyanosis, and intake of fluids which has gone down, and he is very irritable. And this particular child with flu-like symptoms improves, but then maybe he may come back with fever. Influenza is known to have biphasic illness. That means initially for 2 or 3 days, the child is unwell, the symptoms improve, but again on day 4, 5, 6, the child comes back. Okay, so that biphasic fever is very much known in case of children. And in addition, whenever the child has worsening of the respiratory symptoms, in increase in the respiratory rate and pneumonia, we have to be very, very, very careful. Okay, and we are all aware that influenza leads to infection of the ear. It leads to infection of the lungs in the form of either pneumonia or ARDS, and sometimes because of complications, the child can succumb. Okay, now when you come to management, remember, in addition to the bed rest and increase in the fluids and cough suppressants and antibiotics, and maybe NSAIDs for fever and myalgias, most of the patients would recover. But severe cases may require IV fluids and other supportive measures. And the medication oseltamivir, which is a neuraminidase inhibitor. What is this neuraminidase? It's an enzyme. And remember, the viral neuraminidase enzyme is blocked, okay, which is critical in releasing the virions from the infected host cells. So these drugs, they are active against influenza A and B, and they are oseltamivir and zanamivir. Okay, so these are neuraminidase inhibitors. Remember that antiviral therapy with oseltamivir is very, very important, and one must understand it thoroughly. Remember, it's a selective inhibitor of this neuraminidase enzyme. Now, oseltamivir is a prodrug which is converted to the active form oseltamivir carboxylate in the liver, and it inhibits the influenza virus replication and the further pathogenesis, and it prevents the further spread of infection. And it's effective against all the strains of influenza A, B, including avian H5N1 and the swine origin H1N1 and H9N2 and so on and so forth. And this is just to give you a diagrammatic idea about this mechanism of action of oseltamivir. And you can see here that one virion can release many, many new virions. And neuraminidase inhibitors, you can see the red cross which I have put at the bottom, wherein the virion, simply cannot replicate into further viral copies. And this is how the spread is arrested. And this is exactly the mechanism of oseltamivir. And it was the first oral neuraminidase inhibitor. And it has been approved in more than 100 countries and approved by FDA and CDC and American Academy of Pediatrics. And remember an important slide. Of course, the medication oseltamivir is available as a 75 milligram capsule twice daily, and that is for adults. The same dose, when given once daily, is useful for chemoprophylaxis. Now, who are the people who need chemoprophylaxis? They are the ones, as I told you, those who are diabetics and hypertensives and obese and having some basic respiratory problem, kidney disease, those who are on steroids. So those are the ones who can be given it prophylactically if there is a person in the family who has flu. Now, as pediatricians, we are more interested. Remember, the dose of oseltamivir is 3 milligrams per kg in twice daily dosage for therapeutic purposes, while for preventive purposes, in children under the age of 1 year, usually is not given. However, you look at the middle part of the slide and see if a child is under the age of 15 kg, the dose comes to 30 mg twice daily. That is 60 mg per day. That is divided twice daily. And that's why if you have a preparation which has 30 milligrams, it's so convenient that the child can take one capsule in the morning, one in the evening. And the preparation, the capsule of oseltamivir of 30 mg is very convenient. And as you know, unnecessarily when you bring a big bottle of this syrup of oseltamivir, there is a lot of wastage. So a capsule will also save that wastage and it will be economical. So from today onwards, please start using, for a child under the age of 15 kg, 30 milligram capsule in the morning, 30 mg in the evening. And in a child who is about 23 kg, up to 40 kg, it's 120 mg per day. That is 60 mg. That is 2 capsules divided twice daily, 2 in the morning, 2 in the evening. Okay. Of course, all these dosages are very much there in the product insert, but just because, pediatricians usually we deal with children between 10 to 15 kg or maybe in older children. So if you know the dosages for this age range, then you will be comfortable. And remember that the recommended duration for post-exposure prophylaxis, particularly prophylaxis, it is for 10 days. Okay. While for children, for the therapeutic purposes, it is usually given for 5 days, and the treatment should be initiated within 48 hours of the onset of symptoms. Okay. And remember, as I told you, I'll repeat, for weight 15 kg or less, the treatment dosage for 5 days is 30 mg twice daily, and prophylactic dose for 10 days is 30 mg capsule once daily. Of course, if the younger infant is there, you are fully justified in giving a syrup in the dose of 3 mg per kg, and therein you can decide, what would be the dose. 30 mg in the syrup form will come to about 2.5 ml twice daily for therapy, and 2.5 mg once daily for preventive purposes if indicated. Okay. So the dosage convenience, avoidance of wastage, and economy, these are the advantages of this 30 milligram capsule. And there are some benefits of the empiric and early use of oseltamivir. As I told you, basically it reduces the lower respiratory tract complications. If you use oseltamivir, obviously in a child where the throat swab is positive, the antibiotic use will be avoided, and it's a step towards antimicrobial stewardship. Even hospitalization will be prevented, and that is why, remember, reducing the occurrence and the severity of the pneumonia due to H1N1 by early oseltamivir administration. Because if the child continues to have this virus inside, as I told you, 1/4 of them will get secondarily infected because of the damage to the lungs. The bacteria will get an access to the lungs and then create problems of bacterial pneumonia. And that's why you have to be very, very careful that you do not create this particular problem by delaying the treatment. So start the treatment within 48 hours, and patients with a shorter time to oseltamivir administration, they were also discharged earlier from the hospital. Now, some of my friends, they many times ask me that we have been saying that if we use oseltamivir within the first 48 hours of illness, it's fine. The child recovers faster and so on and so forth. The duration of illness is reduced by a day or two. What about if a child comes after 5 or 6 days? My dear friends, remember, even if a child comes little late, you give oseltamivir, because it has been found that the virus continues to replicate and the mortality comes down, and even improvement occurs faster in children who are given oseltamivir even later in the course of illness. That means if a child comes at the day 5 or day 6 of illness, even then you can give oseltamivir, because it has association with reduction in mortality, and also viral replication is controlled even at a later stage. And WHO has recommended empirical therapy very strongly, and the treatment, WHO says, should be started as soon as possible. And laboratory confirmation of influenza virus is not necessary for initiation of treatment, and the negative laboratory test for H1N1 does not exclude the diagnosis in all patients. Therefore, early treatment is to be given. And if the high-risk individuals have been exposed to a patient with influenza, consider presumptive treatment with oseltamivir. Okay, so you have to be very, very careful in understanding this particular subject. So what I would tell you is that if you get a child with all those symptoms of influenza, which I told you, you feel confident in starting oseltamivir, provided epidemiologically there is influenza around. Okay, child who is worsening on day 5 and he is likely to be admitted in the hospital, send the nasopharyngeal swab for influenza. And in those hospitalized or complicated cases, please think of starting oseltamivir. Okay, because an early empiric and supportive therapy and monitoring will be of great importance, because we want to prevent these chaps going into severe acute respiratory infection. And empirical therapy is nothing but the neuraminidase inhibitor in the form of oseltamivir. And of course, in case if there is a history of travel or exposure to animal influenza viruses, again, we have to be careful and start empiric early therapy. Okay. And of course, in adults with community acquired pneumonia who test positive for influenza, whether we should start antiviral therapy. Now, the recommendation says that anti-influenza treatment like oseltamivir should be prescribed for adults with community-acquired pneumonia who test positive for influenza. Okay, and oseltamivir is associated with reduced risk of death in those patients of community-acquired pneumonia who are positive for virus. So for adults, usually the treatment within 2 days of symptoms onset or hospitalization may result in the best outcomes. So my dear friends, there is unusual pattern of influenza in the society. As I told you, it's not something which has now remained seasonal, and majority are H3N2 and influenza B, and the proper diagnosis can and early treatment can prevent flu complications. And the empiric use of oseltamivir will reduce the lower respiratory tract complications and hospitalizations and antibiotic use. And the WHO and the American Thoracic Society and the Ministry of Health and Family Welfare, they have recommended the empiric use of oseltamivir. And my dear friends, I cannot, rather conclude without telling you about influenza vaccine. It is now to be remembered that the new influenza vaccine, the Southern Hemisphere vaccine, has already come in the market. April and May are the best seasons to immunize children. And if you immunize children, all others in the family will be protected, because COVID is an infection which is transmitted from adults to children. Okay, while influenza is the one which is transmitted from children to adults. And if in the family the father is obese, the mother is pregnant, the grandfather is say diabetic, and there are some comorbidities in others in the family, and if a child with influenza spreads the disease to others in the family, it will be very, very difficult to handle all at one time. And that's why a child who is protected with vaccine will always protect others in the family by preventing the transmission. And that's all from my side for this particular moment. And in case if there are any questions, please feel free to put
I have
them.
shared some questions in chat box, sir.
Yes, I will just have a look at that. And I can see about the guide about vaccine updates. As I told you, the vaccine is, available twice in a year in different strains. Right now, the one which has come in the market is something called as the Southern Hemisphere vaccine. See, most of the parts of our country, except the J&K, that is Jammu and Kashmir and Tamil Nadu, the season is usually in the months of, monsoon. And that is why a child protected before monsoon in the months of April and May, because the protection takes at least 3 weeks to start. So if I take it on 1st of April, this child is fit, to face the influenza virus after 21 days. That is from 21st of April. Okay. And that is why earlier the better. And the protection lasts for entire 1 year. We all know that the strains keep changing. I told you in my talk that there are epidemiological, shifts and the drifts, though the minor ones are, always there every year. And these small little changes in the structure of the virus, is the reason for annual epidemics. And the strain in the vaccine also changes accordingly. So it is necessary that the adults as well as children, they receive the vaccine every year, because the strain changes and the protection against that particular strain continues for the next 1 year. Okay. And remember, there are no problems with the vaccine, very, very, very rare side effects of the vaccine. So one need not worry about it. One of our listeners wants to know about whether there are any side effects or any contraindications. I think, Manor, they are related to oseltamivir probably.
Right, sir. Right,
yeah.
Sir.
So remember that nausea and vomiting are known to be associated with oseltamivir. And that's why, in case if you find that the child or the adult, rather complains of nausea or vomiting, it's always better to give a tablet of ondansetron half an hour before the medication is given, or maybe you can give a proton pump inhibitor, and that should avoid this particular problem. Serious side effects are rare, and in case if you give the tablet, please inform the parents that after taking a tablet, please report to us if there is any problem within the next 6 hours. Okay. And there are no contraindications as such for this particular medication. And there is someone who wants to know whether there is any new antiviral which we can expect for influenza. To the best of my knowledge, as of now, there is no new antiviral. Though if I get some information on that, I will pass it on to you, our colleagues. What I would just try to reiterate and again focus is that influenza is a highly communicable disease. The incubation period is very short, even shorter than COVID. And that's why the person-to-person transmission of influenza is very fast. Children spread it to the adults, and that's why protecting children by vaccination is of great help. In case, unfortunately, someone gets influenza, then it is very, very important to give the medication in the form of oseltamivir as early as possible, because earlier you treat, shorter is the duration of the illness. Okay. And even if a child or an adult with influenza comes to you little later in the course of influenza, oseltamivir does help. And that's why we have to be, little careful when there is influenza around, because you don't know as to who is the one who is likely to land up in problem. And in our country, so many children are malnourished and their immunity is on the lower side. And whenever the child comes to the clinic, we really don't know whether this chap will worsen after 2 or 3 days. Sometimes maybe at your place, if a child is brought to you from a long distance, he may not be able to come back again. You may not be available. It could be the night time. And then it could be very difficult to, save this child from either complications or death. And that's why you have to take a prudent and wise decision and decide as to which are the children who could probably be given oseltamivir. However, remember that if a child has very mild influenza-like symptoms like fever, mild throat irritation, mild congestion, and a little bit of runny nose and all, and in case if epidemiologically influenza is around, these are not the children where you need to give oseltamivir. The ones that I told you are the ones who have headache, myalgia, severe weakness, high fever with chills, with epidemiologically high prevalence of influenza in the community. They are the ones wherein you should think of in the first few days. And obviously, in children who are admitted, who are hospitalized, who are high risk and who are likely to get complications, they are the ones where you should be careful about. Okay. So Manor, that's all from my side. If there is anything which you would like me to, tell the audience, please tell me. Yeah.
No, sir. Sir, thank you so much for sharing your valuable experience with the audience. And I also would like to thank, the audience to joining this webinar and sticking till the end. And thanks for your patient listening also. I hope this webinar will definitely be helpful for you in your day-to-day clinical practice. And with this, once again, I would like to thank Dr. Pramod Jog for sharing your valuable experience and clinical experience with the delegates attended. Thank you so much.
Thank you.
Have a great day ahead.
Thank you. So I wish all my listeners a very happy season of the April and May, free from influenza. Okay. And also I wish all their patients, particularly children, remain healthy. And in case if they have any problem, all the information that we have discussed probably would be of great help to them. Thank you.
Thank you, sir. Thank you very much.